The Doctor in a Johnny, What I Learned About Being a Doctor from Being a Patient by Mary Braun, given at the Catholic Medical Center in Manchester, New Hampshire on September 27th, 2016. I am a doctor. I know that when you have a virus, you just wait to get better. But I have a phlebotomist in my office, and I felt so horrible that March afternoon that I ordered a set of labs. It turned out that my blood counts were very dramatically abnormal. That's weird, I thought. I'll have to recheck them in 2 weeks when I feel better. 2 weeks turned into 2 months. It was now mid-June, and 4 hours after I had my labs rechecked, my secretary went running by. Dr. Braun, I'm looking for a doctor to talk with a pathologist, but it can't be you because it's about your labs. She ran off past me, and I went in to my first patient of the day. This was not the best way to learn that something was seriously wrong with my labs. This is an example of bad news and how not to break it. Later in the day, I had the formal breaking bad news talk, and it was similarly non-standard. The tasks of the breaking bad news interview between a doctor and patient are to collect information about what the patient knows and wants to know, to provide the information to the patient, to support the patient as they cope with this information by using skills to reduce its emotional impact, and finally, to develop a treatment plan. Notice that the first goal is for the doctor to learn something. What does the patient know, and what do they want to know? Some of you know the social work maxim, meet the patient where they are. Our first task is to find out where they are and where they are willing to go. When I am on my game and meeting a patient for the first time, I start by asking what the patient has been told about their disease. This is sometimes the most valuable intervention I do in clinic. To find out that a patient thinks their metastatic lung cancer is curable, or to learn that a patient thinks they will get better from their COPD, can be very useful. The second of the 4 goals for the Delivering Bad News interview is to deliver the bad news. We'll go into more detail about how to deliver bad news in a few minutes. The basic thought is gently, kindly, slowly, clearly, and in small doses. Reducing the emotional impact of the news is the third goal. I think sometimes the best way to do this is to sit quietly with the patient while they absorb the news. This can be hard. I notice that people often feel uncomfortable if we're not doing something. Sitting quietly and breathing while your heart beats and the patient collects their thoughts for 30 seconds feels like a huge waste of time, but it's not. It feels uncomfortable the first dozen times you do it, but it gets better. The final goal of the Delivering Bad News meeting is to develop a treatment plan. Don't make it too detailed. Things may change as the patient digests the information you just gave them. There is a protocol for giving bad news to patients. It's called SPIKES, which is a nice mnemonic. Setting includes making sure there's some privacy, including the patient's loved ones, connecting with the patient, and being sure there's a box of tissue handy. I went to find the doctor who knew my news when I was between patients. You know how much time that is? None. She pulled me into her office, looked at me, and burst into tears. She gave me the news while crying, and then we both had to go on with our days. Knee pain, hypertension, and depression follow-ups. In retrospect, this is why one should not order one's own labs. If I had had someone else order them, there would have been a clearly identified person to take the pathologist's call. The secretary's distress would have been less, and there would have been a clearly defined way for me to get my results. The person who ordered them would have tracked me down after work and told me, if you order your own labs, you must be prepared for substandard care. Perception is a reminder to assess the patient's perception. I made this easy for the doctor who gave me the bad news by saying, I hear the pathologist called today about my labs. It happens sometimes that a patient gets fairly far in the system without somehow understanding that they are being worked up for a serious disease. You're here today to talk about your MRI results. To make sure we're on the same page, can I ask you to tell me why we did the MRI? What were we looking for? Invitation sounds silly in a way, and yet it is not. If the patient is there for the results, of course, they want you to give them. However, deliberately asking if the patient is ready to learn the results of the test signals how important the conversation is to the patient and acts as a warning that there is serious stuff ahead. When I got my news this was missing, my friend was in tears. She said something like, "Oh, Mary, I'm so sorry. Weldon thinks you have leukemia." My boyfriend used to own a company. At one point, they had a professional sales trainer come in and talk with their sales force. The trainer pointed out that if you ask permission to talk with your customer about their situation, the person will be more invested in having the conversation because, after all, they did say it was something they were okay with. Knowledge is the part where the doctor gives the knowledge they have to the patient. Your cancer has spread to your liver. The test results show you have MS. Be sure you have the correct information here. The social worker at Mary Hitchcock told me my leukemia had the good mutation. It did not. It had the intermediate one. These little details matter. Treatment for the good mutations is almost no chemo. Optimal treatment for the intermediate mutations is not known. He was not quite clear on the difference. A lot of what I do with people is to go over results. I was recently the fourth in a series of doctors a patient saw about his cancer. He had an MRI in April. The report said there was no cancer in his brain. In August, he had another MRI. The report said that the 3 masses in the brain were bigger than they had been in April. He was puzzled because the report from the MRI in April said there were no masses. No one could explain to him what was going on, and he was stuck, unable to make any decisions about going forward with treatment for those masses that may or may not have been there in April, because he thought maybe the August masses weren't there either. It took several calls to track down the radiologist who realized that with the retrospectoscope, he could see the masses there in April, but it was not at all unreasonable that someone had missed them when they didn't know they were there. Now the patient and his wife could move forward because they finally felt they understood where they were. Emotions and empathy is where the doctor gets a chance to show the patient they understand how the patient feels. A surprisingly empathetic statement is, "I can't imagine how that would feel." It is almost always appropriate, especially if you really try to imagine how it would feel to be told you have a disease with a high mortality rate when you were not yet 50. The woman who told me was hugely empathetic. In fact, she was crying as she told me I had leukemia. This was very kind, but made me feel as though there was no space in the room for my emotions. Strategy allows the patient and physician to plan the next steps together. My plan was simple. The pathologist made you an appointment with the new oncologist tomorrow. Additionally, as soon as I was done with my clinic day, I called the pathologist to see how likely he thought it was that I had leukemia. The patient calling the pathologist directly to go over their results is highly unusual, of course. The last time I checked with Weldon, I was one of 2 patients he had talked with in his career. Back to strategy. Usually, in order to develop a plan, the patient needs an idea of their prognosis. If they think they are likely to live for 5 years without chemo, a treatment expected to give them only 3 months would not look very appealing. However, if they knew the median survival for their disease was 8 months, they might be interested in some suffering in order to gain 3 months. Before I talk about prognosis, I ask the patient for permission again to give them hard facts. I will sometimes say, and people can usually live really good lives for quite a while, and if you want, I can talk more specifically about how long quite a while is, or we can leave it at that. But, people can travel and have parties. Usually the patient will nod their heads or say yes, and I'll move into talking numbers. An advantage I have in this area is that I have taken care of probably a couple thousand dying people, so I can honestly say, in my experience, people with disease like yours usually have a prognosis of thus and so. When I was diagnosed with leukemia, no one told me a word about my prognosis. I was left to wonder if I was likely to die soon or likely to need a transplant, or if I'd be dealing with the leukemia for the rest of my life, or if it would just go away and be a memory. I had had patients die from leukemia when I was a student, and in every stage of my career since then. Lying in the hospital bed, I tried to prevent myself from going there. I simply walled it off. Things had started to go badly for me. If I got an overwhelming infection or started bleeding out, no one would have known my wishes for end-of-life care. This would have decreased my chances of getting what I wanted, as none of my doctors was very good at reading my mind. Let me tell you what they would have learned if they had been able to read my mind. Room 113 was a single with a bed on one wall and a clock on the other. The clock looked like every other hospital clock I've ever seen. Plain, white-faced black letters, secondhand going around inexorably. Every time I glanced at that clock, I thought about how, at the end of a code, the person running it says, it's 12:13. Unless someone has an idea, I'm going to call it. The time of death on the certificate is 12:13, the end of the code. Every time I checked to see how long until lunch or when I could expect a visitor, I would think of how the person running my code would do exactly what I was doing, except I would be newly dead. Every time. If you want to know how many times you do something in a day, attach a strong emotional value to it so that every time you do it, you are forced to bring your whole attention upon it. You'll find out that you look at the clock above your bed often. I did not talk with anyone about this at the time, nor did I ask my team much about my prognosis. If someone had asked me what I thought, I would have said, I've seen several people die from AML, and I've never seen anyone who had AML and was now cured. I don't have anyone who's living with AML among my primary care panel, so I'm guessing it's pretty universally fatal. I had seen people get transplants and suffer for a year or two in and out of the hospital with obscure infections, only to die after an emotional family meeting where the family decides to stop technological support. I did not know anyone who had had a transplant for AML and done well. I did not know anyone who had had chemo for AML and done well. That was what I had in my head those first few days of Leukemiaville. Over the next days, Dr. Hill told me that we were waiting for the genetic studies of my leukemia to come back. We already talked about that. I was given the wrong information initially. The real information did not help me figure out if I was going to die in that hospital bed in the near future or not, because the intermediate genetics AML has a wildly variable prognosis. Then, about 2 weeks into my hospital stay, lying in that very bed, looking at the ceiling, one morning after the onslaught of the vitals, labs, resident exam, and fellow exam, but before breakfast and the attending exam, I decided to think about my prognosis. People who know me well know that I sometimes give advice that says you have to take yourself by the hand and do this thing that scares you. That is what I did. I took myself by the hand and thought about how likely I was to die from this leukemia in the near future. I made myself think about what kills leukemia patients. Overwhelming infection, not going into remission, bleeding, dwindling. I was unlikely to do any of those things in the next month. Further down the road, people die from not getting their infections treated in time or by getting horrible infections. I was unlikely to wait too long and could not control if I contracted a resistant bug. Even further down the road, people die from transplant complications, but I didn't even know if I would need a transplant. I could be killed in a traffic accident in that amount of time and would forego worrying about transplant complications at this point. I decided that late June morning that I was not likely to die anytime soon from my leukemia. I could relax and check the clock, knowing I was likely to die somewhere besides that hospital room. Eventually, I went home and began to pore over the Kaplan-Meier graphs for AML. I learned what the prognosis for people in my age group with my markers is. I know that almost everyone listening to my talk is fond of me, and some of you really love me. Few of you love me very much. Even those who love someone the very most are not likely to be as interested in their prognosis as the person themselves is. You really want to know, what are Mary's chances, right? Imagine how much more I wanted to know. We often balk at giving patients our guess at their prognosis. I don't really know. I can't predict the future. I don't want to make them think about death. Think about that story I just told you. Every single time I looked at the clock, I thought about death. Every single time I looked at the clock, I thought about death. Do you think someone talking with me about my prognosis would have made me think about death more? Do you think that is possible? Patients know that people die from cancer. They already know they're likely to die from this disease that has taken over their lives with chemo and doctor's appointments and hospital stays. You're gently asking them about it will not make it any more real for them than it is already. I will almost always say to my new patients that I know you've thought about if this disease will kill you or not and what that might look like. I used to be a hospice doctor, so I've been with probably 1,000 people as they've died. I can't tell you what it feels like to die because I've never done it, but I can tell you what it looks like. If you want to ever talk about what the future might look like, if you want to talk about it now or at some point in the future, we can do that. About half the time, people ask me to talk about what death from their disease looks like and how long I think they might have. I suspect the fact that there is a Kaplan-Meier curve that is relevant to my life gives me a certain authority with patients that other people might not feel they have. I'm going to let you in on a secret, though. The Kaplan-Meier curve for all humans goes to zero after 100 years or so. Not a single one of us is going to survive forever. We all have the authority to speak from the human condition. If I might be so bold, I would suggest that some of our reluctance to speak about death with our patients comes from a belief that we doctors are not exactly the same as other humans. This could not be more wrong. People tell me that it is a relief to have an idea of what they might be facing, and what I tell them I think is coming is inevitably better than what their imaginations had created for them. What we say to patients is important. I think when I say something big deal, I listen to myself going on all day and I don't really say anything special. Why would anyone listen to me? But to patients, what I say means something. When I was a very new doctor, a pediatrician said that a mom had recently thanked him for something he had said at her well child's check when the child was 1 or 2. This was 18 years ago. The pediatrician had no recollection of that well child check 18 years before. To him, it was one of 20 or 30 visits that had happened that day. But to the mom, the doctor's advice to tend to her relationship with her husband for the good of her son was incredibly special, and she had treasured what he said for the rest of the kid's growing up years. What we say matters to patients. It can go the other way, too. An unthinking statement from a doctor can make things harder for a patient. I will often see people who have end-stage kidney disease, bad COPD, congestive heart failure, and by the way, metastatic lung cancer. One well-meaning doctor will say, from a cardiac point of view, you're going to live to be 100. I think the doctor who says this means that the patient has worse problems than their heart, but sometimes patients hear this as, your heart is fine. A few months later, when the oncologist thinks it's time to stop chemo and says, your heart and kidneys are compromised, the patient recalls that their heart doctor said their heart was fine and feels the oncologist doesn't know what he's talking about, or hasn't talked with their heart doctor, or is withholding chemo for some other reason. What we say matters. It's not just what doctors say that matters either. Recently, a patient with COPD and lung cancer was admitted to CMC here for a COPD exacerbation. She was considered and called her oncologist's office to tell them she was in the hospital, so she'd have to cancel her appointment. The secretary said, that's just fine, Mrs. Smith. You put your lung cancer on hold and concentrate on getting better from your COPD. We'll see you when you get out of the hospital. A few days later, when someone tried to talk with her about her lung cancer, she became angry. The people at my cancer doctor's office told me to put my cancer on hold. They are the ones who know about it. Who are you to tell me it's getting worse? How dare you? They said I could put it on hold. The secretary, completely unintentionally, gave the woman just what she needed in order to be in denial. Certainly the patient was complicit in the denial, but the secretary gave her the raw material. What we say matters. A search of the medical literature for giving sad and bad news reveals that doctors are uncomfortable giving this news and suffer themselves when they do so. That patients' hope is not destroyed even when given information that is very blunt. That few older doctors have gotten any training in this, but most younger doctors have. That most doctors do a good job of being supportive, but giving prognostic information and referring to support groups are the areas doctors are weakest in. That there aren't any trials of different ways to deliver news. That when the doctor and patient are from different cultures, it gets even more complicated. The trauma surgeons and pediatricians think a lot about delivering bad news. Oh yes, and how we do it makes a difference to patients with respect to their attitudes toward medical care. Clinicians down the road. Here is another protocol, breaks. Background, know your patient's medical, cultural, and psychosocial situation. Rapport, If you are not previously well connected to the patient, spend some time getting to be. Explore. Find out what they know and what they are expecting, as well as how much information they want. Announce, I have some bad news. Is it okay if I tell you? Keep it simple. These authors recommend no more than 3 pieces of information at a time. Kindling, caring. Respond to the emotions that the patient brings to you. Summarize, and figure out what's next. These conversations can be tough and exhausting, but they are so important. People tell me stories all the time about doctors and nurses who help them by being kind, and from time to time, they tell me stories about ones who made things harder, usually by unintentional tiny things that made the patient feel they didn't care. You need to be prepared for how the patient will respond when you give them bad news. We doctors are comfortable with all bodily fluids except one: tears. We've gotten good training on not running away from CSF, pus, or blood. Our training could be better on how to endure tears. You need to have some ability to sit there while the patient cries. Count to 3. Here are 3 things. 1, offer a tissue. 2, say, I can't imagine how hard this must be. Or, I can't imagine how this feels. 3, say, this is lousy. Or, this is not the news I was hoping to give you. Usually with me, patients respond with sadness, but sometimes they get angry, especially if there have been mistakes or delays of diagnosis along the way. This one is harder for me to deal with, but I think the key is to avoid defensiveness. Just like with tears, it can be helpful to let the emotion play itself out for a few moments. It feels awkward to sit and listen, but is one of the most powerful things we can do. It is lousy news is usually a helpful response. And for all our attempts to communicate well and compassionately, things can go very wrong. There is a study done on patients with incurable lung and colon cancer. A huge portion of them felt their cancer was curable, which is just plain wrong, given our current treatments. And the ones who were wrong were more likely to think their doctors were good communicators. What does this mean? That people who get one fact wrong, that their cancer is curable, are more likely to get other facts wrong, that their doctor is good at communicating? That patient satisfaction is not always a useful way to measure quality of care? Let's get back to me and my cancer story. How much of my story is appropriate to share with patients? I do not usually tell my patients about my leukemia. I don't care if they know. I even blog about it. However, I try to keep it out of my clinical encounters because I feel disclosing this fact moves the focus off of the patient and onto me, which is undesirable. But there are times I do disclose it, usually with a very particular clinical aim in sight. Fairly soon after I came back from my 6-month chemo vacation, we had a patient at the hospice house who had locally very advanced ovarian cancer. She had come to the hospice house because she would tell her family she was fine on the phone, and they would find out later she'd been lying on the floor, unable to get up after a fall, at the very moment she had been telling them she was fine. She didn't want to trouble them. She was very difficult for the hospice staff, too. Despite my talking with her and giving her statistics about how unlikely CPR would be to help her, she insisted on being full code. She did all of her own self-care, even though the staff were terrified she was going to fall over in the bathroom as she stood in front of the mirror putting on her makeup. She insisted she was getting better and going home in a few days. She would not tell her family what she wanted for a funeral or where she had bank accounts. She simply would not acknowledge that she was dying. This was despite the fact that she weighed about 90 pounds and could barely walk. One morning I went in to round on her and she told me that the night nurse had told her about my cancer. Yes, I had leukemia. I had chemo for about 6 months. Did you lose your hair too? Yes, I did. I was bald too. The nurse says you're in remission. Am I in remission? Now, obviously, she was not, and I knew she had been told this 100 times, but I responded as though we had not had this conversation just yesterday. No, I am sorry to say you are not. I didn't think so. That afternoon, she changed her code status and talked with her family about her funeral arrangements. I don't really know if it was my disclosure that made the difference for her or not, but I suspect that comparing her body to mine may have been the concrete message that she could not deny. I was vigorous, energetic, and she was not. She was dying, and I was not. Let me tell you about a couple of other experiences the cancer gave me that you might find useful. I was tremendously lucky and did not really suffer when I had cancer. You hear about people who have a very hard time of things, and certainly I had some pain, a little vomiting. There were times I was scared and sad, but I did not really suffer. Why I think this would be a topic for would be a topic for another day. But what I wanted to talk about now is the one time I did suffer. After my second round of chemo, I had a neutropenic fever. My temperature was higher than the thermometer registered. When the ambulance delivered me to Lebanon, I was so weak I could not participate when they moved me from the stretcher to the bed. I spent 4 days with fevers over 101, then another week with fevers up to 101, and then finally I got better. I had such bad rigors I gave myself TMJ. I had stage 1 bed sores on both hips because all I could do for a week was to shake and flip from one side to the other. I was so delirious that I was visited by a hyper-religious, decrepit talking basset hound. I looked at the end of this time like a thin, weak version of myself. No one in Lebanon noticed that I was not quite thinking normally yet. The basset hound was no longer visiting me regularly, but I couldn't really understand what people who are unfamiliar to me were saying. I could smile and nod, and that's all strangers really expect anyway. I couldn't attend to more than one thing at a time, such as drinking a cup of coffee and having a conversation. This got better slowly. After about half a week, I could see I was much better. That was when my now ex-husband talked with me about it. You know, my sister and I have noticed that your thinking is not quite as good as usual. We don't think you should drive right now. I hesitate to mention the specific restriction they placed was driving, because people always misunderstood this point. What bothered me was not the driving. Driving took more energy than I had anyway. I didn't want to drive, and if asked, I would probably have agreed I shouldn't be driving. What was horrible for me was that I knew they were right, and my thinking had not been perfect. But I thought it was getting better. To be told now, when I thought it was almost normal, made me feel I could not trust my own evaluation of my thinking. I was thinking well enough to know that there was nothing I could do or say to convince someone else that I was thinking well. The more I said, ask me questions, have me explain what I would do if I saw a stamped envelope on the ground, let me tell you a story, the more ridiculous I would sound. I was not 100% certain my thinking was completely normal at that point. In fact, I knew it was not, but I thought it was close enough. They thought it wasn't. It was terrifying to think I might never be able to trust my own evaluation of my mind again. That was the suffering. When I see patients who are just a little bit delirious, I can sympathize very deeply. To be thinking just a little off and to know it is terrifying. This is the one case where I will tell patients and families my story, and I think it really helps. I could tell you lots of stories about this, and they are all basically the same. Delirium is terrifying to patients and frustrating for families. Helping patients understand that this is the disease and not them, and helping families understand that the patient is not being difficult on purpose can make all the difference in the world. Delirium is a huge cause of suffering, is super common in hospitalized and I suspect ambulatory patients, and there are lots of things we can do that help a little bit. There are a dozen or so screening tools. It seems the most widely used one is the CAM, Confusion Assessment Method. In order to be delirious, a patient needs an acute change in their thinking, a fluctuating course, and inattention. Consider delirium in that patient who gets difficult at sundown, whose family says, "This is not Aunt Martha." That the researchers call it inattention is difficult for me. When I could not follow a conversation and smiled and nodded, I suspect it looked like inattention. It did not feel that way. I felt that my will was attending and attending hard. My brain just could not. Finally, to be delirious, a patient needs an altered level of consciousness or disorganized thinking. The altered level of consciousness can be subtle and can be that the patient is more sleepy than usual. Do not be fooled by hypoactive delirium. The patient who sleeps constantly and when he wakes up doesn't make any sense might be delirious rather than sleep deprived. I have seen a patient be so delirious with pain that when you woke him, he could not recognize his mother. Yet if you left him unstimulated, he would fall asleep. 20 milligrams of IV Dilaudid later, he was walking and talking and completely coherent. Think how Narcan would have added to his misery. Please don't forget hypoactive delirium. Earlier, I said you shouldn't give more than 3 bits of information at a time. Here are the 3 things I want you to walk away with. 1. What we say matters. 2. When patients want to know their prognosis, give them an honest answer. 3. We can all speak with authority from the human condition as long as we are willing to be human. That brings me to the final sentences. There have been so many kindnesses that have gotten me here. Thank you, thank you, thank you. I would not change anything of my journey, even if I could, because to do so would jeopardize the present, which is so precious. I'll take questions now. Thank you.